Hello, my name is Garrett Bragg, and I am currently a psychiatric mental health nurse practitioner student at Colorado State University in Pueblo, Colorado. This presentation is part of my oral comprehensive examination and fulfills a portion of the requirements for completion of my graduate program. This presentation will explore a timely and clinically significant topic in psychiatric mental health nursing: the comparative effectiveness of cognitive processing therapy and selective serotonin reuptake inhibitors in the treatment of post-traumatic stress disorder among veterans. This discussion is not only about treatment choices, but about our broader role as advanced practice nurses advocating for high quality, evidence based, and culturally competent care. Before I start, I'd like to quickly go over some of the key acronyms and terms used throughout this presentation. Understanding these will help solidify our grasp of the treatment approaches and tools involved in PTSD care. PTSD stands for post-traumatic stress disorder, a psychiatric condition that can develop after experiencing or witnessing traumatic events. It's the foundation of our discussion today. CPT, or cognitive processing therapy, is a highly effective structured talk therapy. It helps patients challenge and reframe unhelpful thoughts related to trauma. SSRIs, or selective serotonin reuptake inhibitors, are a class of antidepressants commonly used to treat PTSD symptoms like anxiety and hyperarousal. The DSM-5/TR is a diagnostic and statistical manual of mental health disorders, the fifth edition, and is a standard manual for diagnosing mental health disorders accurately. PCL-5 is a PTSD checklist for DSM-5, a standardized self-report scale that tracks symptom severity. It's a central tool in measurement-based PTSD care. EBP, or evidence-based practice, refers to using current research, clinical expertise, and patient preferences to guide treatment decisions. The ARCC model stands for Advancing Research and Clinical Practice Through Close Collaboration. It's a change model used to promote evidence-based care in clinical settings. The VA/DoD refers to the Department of Veterans Affairs and Department of Defense, which publish clinical practice guidelines specifically for service members and veterans. APA is the American Psychiatric Association. The APA is the leading organization advancing psychiatric care research and education. An MSE, or mental status examination, is a structured clinical assessment used to observe a patient's appearance, behavior, and cognitive functioning. EMR stands for Electronic Medical Record. It's a digital chart used to document assessments, treatment plans, and symptom progress over time. PHQ-9 is a patient health questionnaire 9, a brief scale used to assess depressive symptoms. FDA is a federal agency that regulates the safety and effectiveness of medications, medical devices, and food products in the United States. It ensures that treatments like SSRIs are scientifically tested and approved for use in clinical practice. The ANA Code of Ethics is an ethical framework guiding advocacy, dignity, and nursing integrity. NICE, or the National Institute for Health and Care Excellence, is a UK-based organization that develops evidence-based guidelines to improve health and social care. It helps providers make informed, standardized treatment decisions. The NONPF is the National Organization of Nurse Practitioner Faculties. It sets the national standards for NP education, or nurse practitioner education, and core competencies, ensuring nurse practitioners are prepared for advanced evidence-based patient-centered care. And lastly, the GAD-7 stands for Generalized Anxiety Disorder 7-item scale, used to screen and measure anxiety severity. Now that we've reviewed these terms, you should have a solid understanding of the core concepts and tools in modern PTSD treatment for this presentation. Let's begin with my PICO question. In veterans diagnosed with PTSD, how does cognitive processing therapy compare with FDA-approved SSRIs in improving a patient's PCL-5 scores over a 6-month period? This question reflects the importance of evidence-based inquiry in advanced nursing practice, driving our clinical decisions and ensuring accountability in treatment planning. Allow me to introduce John. John is a 34-year-old Army veteran with a history of combat exposure and a diagnosis of PTSD. His core symptoms included hypervigilance, frequent nightmares, and intrusive thoughts related to his deployment experience. To begin treatment, he was prescribed sertraline, a first-line SSRI for PTSD, and prazosin, a medication used to treat nightmares. Unfortunately, John reported gastrointestinal discomfort and little symptom improvement. His PCL5 score remained high at 64, suggesting a severe symptom burden. This prompted a reassessment of his treatment plan, considering a non-pharmacological intervention such as CPT. As an advanced practice nurse, applying up-to-date clinical guidelines is essential in delivering evidence-based care. According to the VA-DoD, APA, and NICE, cognitive processing therapy, or CPT, is recommended as a first-line treatment for PTSD, particularly in veteran populations. These recommendations are grounded in high-quality evidence, including randomized controlled trials and systematic reviews. For example, research by Monson et al. And Gutner et al. Provides compelling support for the use of CPT over SSRIs, showing greater symptom reduction in PCL5 scores. These studies represent a high level of the hierarchy of evidence, which is vital for guiding our clinical decisions. However, there are notable gaps in the literature. There's limited data specifically addressing female and minority veterans, and few long-term comparative studies. Additionally, access to CPT remains a challenge, especially in rural VA clinics where therapy services may be limited. This has direct implications for our advanced practice role. We must advocate for improved access to evidence-based psychotherapies like CPT. We also play a crucial role in shared decision-making, educating veterans about their treatment options and empowering them to choose what fits best for their goals and values. At the point of care, we can apply this evidence practically by administering the PCL5 every 2 to 4 weeks. This supports measurement-based care and ensures we're tracking response and adjustment treating in real time. In summary, applying the highest standards of evidence means not only knowing the guidelines, but also using them to drive patient-centered care, address systematic gaps, and lead change in clinical practice. This evidence table synthesizes recent high-level studies and guidelines that consistently favor CPT over SSRIs for the treatment of PTSD, particularly in veteran populations. For instance, Monson conducted a randomized control trial demonstrating that CPT led to a greater reduction in PTSD symptoms than sertraline, with average symptom reductions exceeding 30 points. These improvements were not statistically significant, but also clinically meaningful, surpassing the 10-point threshold typically used to indicate significant symptom change. Watts further supported these findings in a meta-analysis of over 30 RCTs, including that trauma-focused therapies like CPT result in higher remission rates and lower dropout compared to pharmacologic monotherapy. Clinical practice guidelines align with this data. The VA, DoD, and APA both recommend CPT as a first-line treatment for PTSD. These guidelines emphasize that while SSRIs can be effective, especially in cases with comorbid depression or limited access to therapy, they should be considered secondary or adjunct to evidence-based psychotherapy. Moreover, CPT has the advantage of long-term symptom relief, better functional outcomes, and higher patient satisfaction compared to SSRIs, which are associated with adherence issues and side effects like sexual dysfunction and weight gain. This body of evidence supports our role as advanced practice nurses in prioritizing trauma-focused therapies like CPT when designing treatment plans for veterans with PTSD. Advocacy in advanced practice nursing must address the legislative, regulatory, and standards-based frameworks that impact care delivery. One of the clearest advocacy needs is ensuring reimbursement parity for CPT through federal and state policies. This supports equal access to first-line PTSD care. Advanced practice nurses should also back legislation that expands our scope of practice to allow for direct CPT referrals and management of integrated PTSD care models. On a regulatory level, advocating for CPTs, inclusion in national quality benchmarks, and EMR triggers can ensure its consistent application. All of these efforts must align with the ANA Code of Ethics, specifically Provisions 1 and 8, and clinical guidelines from the VA DoD and APA, which clearly prioritize CPT as a standard of care. As advanced practice nurses, it is our responsibility to lead and support advocacy that transforms these guidelines into practice across diverse symptoms of care. For this presentation, I chose the Roy's adaptation model as the framework in treating veterans diagnosed with PTSD. This model is particularly useful for understanding and treating PTSD because it views the individual as a complex, adaptive system. PTSD disrupts a person's ability to respond appropriately to internal and external stimuli across multiple domains. In the physiologic mode, PTSD often presents as chronic hyperarousal and disrupted sleep patterns, which can be addressed with SSRIs or other healthy strategies. The self-concept mode is critical because PTSD often erodes identity, particularly in veterans. CPT helps patients redefine self-perception and challenge trauma-related distortions. The role function mode is essential as many veterans disengage from family or occupational roles. The advanced practice nurses supports role reintegration with function-focused care planning. Lastly, PTSD impairs emotional connection. Roy's interdependence mode highlights the need for therapies that rebuild interpersonal trust and connection. Overall, Roy's adaptation model provides a holistic trauma-informed framework to support adaptive healing in veterans with PTSD. With my evidence-based practice change model, I picked the Advancing Research Through Close Collaboration, or the ARCC model, because it is particularly valuable for veterans with PTSD because it focuses on building a sustainable culture of evidence-based practice. This model begins by assessing an organization's readiness to implement evidence-based approaches, which is crucial in identifying system barriers to care such as stigma, lack of interprofessional collaboration, or outdated practices. It also empowers advanced practice nurses and other team members to serve as mentors, building a culture where trauma-informed, evidence-based approaches are embraced and supported long-term. For veterans who often require coordinated and sensitive care, this model provides the structure needed to ensure high-quality interventions are not only adopted but maintained. The ARCC model encourages close team collaboration, fosters shared accountability, and embeds evidence-based values into daily clinical decision-making. In essence, it supports both system-wide and patient-level improvements, making an ideal framework for supporting long-term mental health care in veteran populations. SSRIs are considered a first-line pharmacologic treatment for PTSD, and they are FDA approved for this purpose. In veteran populations, sertraline and paroxetine are among the most commonly prescribed. These medications can help reduce core PTSD symptoms, including re-experiencing avoidance and hyperarousal. SSRIs are especially useful when access to trauma-focused therapy like CPT is delayed or unavailable. However, their effectiveness is often modest, and they come with common side effects like sexual dysfunction, GI upset, and insomnia. Advanced practice nurses must closely monitor for adherence and response, especially in veterans who may be managing multiple comorbid conditions or have had variable experience with psychiatric medications in the past. CPT is the gold standard and is the treatment choice in clinical practice guidelines. Trauma-focused therapy specifically designed to address the cognitive distortions that keep PTSD symptoms active. It helps patients identify maladaptive beliefs, also called stuck points, that are tied to trauma, such as beliefs about safety, trust, and self-worth. For example, a veteran may believe, "I should have done more," or "I'm permanently broken." CPT helps patients evaluate those beliefs through cognitive restructuring techniques. These include structured worksheets, thought records, and guided questioning that teach patients to analyze their beliefs for accuracy and utility. A key component of CPT is the trauma impact statement, a written narrative that asks the patient to explore how the trauma affected their identity and worldview. Over 12 sessions, CPT works to replace distorted thinking patterns with more balanced, evidence-based perspectives. CPT is endorsed by multiple major guidelines, including the Veteran Affairs, Department of Defense, American Psychiatric Association, and National Institute for Health and Care Excellence. It is shown to significantly reduce PCL5 scores and improve emotion regulation, interpersonal functioning, and quality of life in veterans. Measuring treatment progress is essential. My PICO question is specific to the PCL5 tool/assessment, and I will mention the evidence-based practice for why I chose the PCL5 on the next slide, but I wanted to point out other useful quantitative assessments that could be utilized in assessing someone for PTSD. The important thing to remember is that these assessments need to be regularly used for guidance and treatment adjustments based on the measurement-based care. That being said, advanced practice nurses should incorporate these tools into every patient encounter. PCL5 is the scale of choice for evaluating PTSD in veterans because it aligns with the diagnostic structure outlined in the DSM-5 and is recommended by the Veterans Affairs and Department of Defense clinical practice guidelines. This tool includes all 20 PTSD symptoms, which allows for comprehensive assessment and monitoring of progress. It's been specifically validated in veteran and military populations, making it highly applicable. The score quantifies symptom severity, aids in diagnosis, and tracks treatment response. Scores below 33 often reflect symptom remission, and a change of 10 points is considered clinically meaningful. Its quick, self-administered design and flexibility in delivery make it ideal for use in both outpatient and telehealth settings. Here is a picture of the PCL5. As you see, it includes 20 items, each corresponding directly to one of the DSM-5 criteria for PTSD. Patients are asked to rate how much they were bothered by each symptom in the past week, using a scale from 0, not at all, to 4, extremely. The total score can range from 0 to 80, with a score of 33 or higher typically suggesting probable PTSD. A reduction of 10 points or more is considered clinically meaningful improvement, which is how we measure treatment outcomes, especially when comparing interventions like CPT versus SSRIs. The PCL5 is quick to administer, 5 to 10 minutes, and can be used in digital, in paper, or EMR integrated formats. It supports measurement-based care, helping providers make informed treatment decisions and track progress over time. In veteran populations, it's validated, easy to understand, and aligns perfectly with VA DoD clinical practice guidelines. As advanced practice nurses, we are in a pivotal position to lead quality improvement initiatives that improve PTSD care delivery. First, we can implement the PCL5 as a routine measurement-based care tool. By embedding it into the electronic medical record and training staff on interpretation, we create a consistent standard for monitoring symptom progression and adjusting treatment plans accordingly. Second, we can streamline access to evidence-based psychotherapy by setting up EMR-triggered CPT referral pathways. When a PTSD diagnosis is entered, the EMR can prompt clinicians to initiate a referral to CPT-trained therapist, ensuring that first-line therapy isn't missed. These two initiatives support guideline adherence, ethical practice, and better long-term outcomes for veterans with PTSD. One ethical dilemma we face is the imbalance between access to evidence-based therapy like CPT and the easier default to SSRIs, especially in under-resourced clinics. This raises concerns about equity, informed choice, and potential harm from some suboptimal care. As advanced practice nurses, we must advocate for fair access, promote trauma-informed alternatives, and ensure patients are fully informed of their options, even when the system doesn't make it that easy. Cultural sensitivity means more than translation. It means understanding how trauma, trust, and healing look different across cultures, backgrounds, and individual experiences. Whether it's a rural veteran, a female service member, or someone from a historically underserved group, our approach must be adaptable, respectful, and responsive. Next few slides show how each of the 10 ANA Code of ethics provisions directly affect clinical work with veterans experience PTSD. Provision 1, Compassion and Dignity. We start by honoring the inherent dignity of humanity of each veteran. Many carry complex trauma, and it's our duty to approach each one with respect, non-judgment, and cultural humility. Provision 2, commitment to the patient. Our loyalty lies first with the patient, whether that's an individual veteran, their family, or the broader population we serve. We prioritize their recovery goals, preferences, and voice in care planning. Provision 3, advocacy and safety. This includes building trusting relationships, ensuring psychological safety, and speaking up when veterans aren't getting access to trauma-informed, evidence-based care like CPT. Provision 4, responsibility and practice authority. We are accountable for our clinical decisions and must advocate for best practices like measurement-based care and support trauma recovery through appropriate diagnosis and treatment. Provision 5, moral duty to self. We can't care for others unless we care for ourselves. Nurses deserve safe work environments, support for secondary trauma, and time of reflection and professional growth. Provision 6, ethical work environment. Each of us contributes to the culture of our unit. We help build ethical, trauma-informed environment, fostering open dialogue and modeling respectful, patient-centered behavior. Provision 7, advancement of the profession. This includes integrating evidence-based research, initiating QI quality improvement projects, and sharing knowledge that helps shape policy and improve mental health care for veterans. Provision 8, collaboration. We're most effective when we work across disciplines, with social work, psychology, and pharmacy, and case management to ensure veterans receive holistic, coordinated care. Provision 9, social justice. We're ethically obligated to challenge inequities, whether they're related to race, geography, gender identity, or systems barriers. That includes advocating for access to therapy and telehealth. Provision 10, global and environmental health. Finally, we align with national and global efforts to promote human flourishing, sustainability, and access to mental health care as a human right, not just a service. Technology is transforming how we use the PCL5 to assess and monitor PTSD in veterans. Mobile apps allow patients to complete the PCL5 remotely, streamlining data entry and improving engagement. When integrated with EMRs, clinicians can view trends over time through visual dashboards. AI tools can assist in analyzing scores to predict relapse or the need for treatment adjustments. Natural language processing can add insight during verbal assessments, identifying distress through tone and word usage. Gamification increases patient interaction, particularly among younger veterans. Telehealth platforms support adaptive PCL5 delivery, customizing questions based on symptom severity. Wearable devices, though not yet standard, offer exciting opportunities to align subjective reports with objective sleep or stress data, creating a more holistic picture of a veteran's mental health. The next two slides outline how the care of veterans with PTSD embodies the full scope of the National Organization of Nurse Practitioner Faculties, or the NONPF, particularly in patient-centered care, cultural sensitivity, clinical reasoning, advocacy, and interprofessional collaboration. Person-centered care, or Domain 2. As advanced practice nurses, we're expected to provide care that is holistic, individualized, and evidence-based. This includes engaging in mutual decision-making with the patient, incorporating cultural beliefs, trauma needs into the treatment plan. For example, we use the PCL5 not only to track outcomes, but also to align treatment with patient goals. Cultural sensitivity and holism, Domains 2 and 9. Care is never one size fits all. Veterans come from diverse cultural, ethnic, and military backgrounds. The NONPF emphasizes the advanced practice nurse role in honoring diversity, equity, and inclusion, and demonstrating ethical comportment and respect for human dignity in every patient interaction. Diagnosis, treatment, planning, and risk mitigation, Domains 2 and 5, using advanced health assessment, critical thinking, and diagnostic reasoning, we synthesize trauma history, symptom burden, and risk factors to develop and revise treatment plans. CPT may be the best path forward for one patient, while another might benefit from a phased combination with pharmacologic support. Advocacy and resource utilization, domains 3, 6, and 7. We advocate for equitable access to care such as tele-CPT for rural veterans and work across systems to leverage community-based resources. The nurse practitioner role core competencies emphasize understanding population health and stakeholder roles. Domains 3 and 6 to guide referrals, consults, and long-term planning. Care coordination and team roles. Domain 6. PTSD care isn't delivered in silos. We lead coordination among PCPs, social workers, pharmacists, and psychologists, ensuring that every stakeholder knows their role. The competencies emphasize both intra and interprofessional communication and the ability to adapt within teams, whether we're leading or collaborating. Some research gaps that were identified include the underrepresentation of women and minority veterans and few long-term randomized controlled trials. Many clinical trials have historically focused on male, predominantly white veteran populations. This limits our understanding of how CPT and pharmacologic treatments perform in women, racial and ethnic minorities, or veterans with intersectional identities. More inclusive research is critical to promote equitable care. Few long-term randomized controlled trials. Most studies stop at 12 to 16 at the 12 to 16 week mark. While that's helpful for assessing short-term gains, PTSD is a chronic condition, and we need data on sustained recovery, relapse rates, and how treatment effects evolve over time. Longitudinal studies are still relatively scarce. Implementation challenges in rural VA clinics. Even if CPT is the gold standard, delivering it in rural or under-resourced VA settings remains a challenge. Barriers include lack of trained providers, infrastructure issues for telehealth, and workflow limitations. Implementation science is needed to understand how to bridge these gaps at the systems level. Back to the case study on John. Given John's limited response to pharmacotherapy, he was referred for CPT. He completed a full 12-session protocol for CPT. Over 6 months, he experienced a clinically significant reduction in symptoms. His PCL5 score dropped from 64 to 30. John noted that his nightmares became less frequent and less distressing, and he was better able to manage his triggers. He also reported improved emotional regulation and began reconnecting socially, attending family gatherings he had previously avoided. This case highlights the limitations of medication alone and the power of psychotherapeutic interventions in PTSD care. Advanced practice nurses are central to orchestrating interprofessional collaborations for veterans with PTSD. We can lead treatment teams by coordinating dual modality care, pharmacotherapy with SSRIs and trauma-focused therapy like CPT. For example, we may prescribe and monitor SSRIs while maintaining open communication with psychologists delivering CPT. The PCL5 should be embedded as a shared tracking tool used by all team members to assess progress and guide treatment adjustments. Collaboration with primary care providers helps manage medical comorbidities and monitor for medication side effects. Pharmacists offer insight to adherence and drug interactions. Social workers address systemic barriers like housing or access to care. Regular case reviews and transparent EMR documentation help unify efforts and ensure patient-centered care, trauma-informed care. This model not only aligns with American Nurses Association Code Provision 8, but also supports high-quality, ethical, and evidence-based practice. Advanced practice implications should include evidence-based leadership. Advanced practice nurses serve as clinical leaders who translate high-level research into individualized real-world care. They evaluate hierarchies of evidence and consider gaps in population representation, long-term outcomes, and implementation feasibility. Implications include using clinical judgment to recommend CPT as a gold standard and address system-level barriers to its delivery. Another implication is focusing on trauma-informed patient-centered care. Veterans' trauma experiences are complex and personal. Advanced practice nurses must center care around the patient's preferences, culture, values, and readiness. CPT empowers patients to regain agency, while SSRIs may be preferred by others due to accessibility or symptom severities. Implications include engaging in shared decision-making, use of tools like PCL5, and adapting treatment plans across time and trauma profiles. Interprofessional collaboration should also be included. Optimal PTSD care demands collaborations between advanced practice nurses, psychologists, social workers, primary care providers, and pharmacists. The implication: advanced practice nurses lead coordination, clarify team roles, and ensure continuity of care, especially during transitions. Advocacy and policy change. Advanced practice nurses must advocate for expanded access to CPT, inclusive research fundings, and telehealth solutions, especially for rural or marginalized veteran populations. Implication: participate in policy efforts, committee work, or local quality improvement initiatives that remove treatment barriers. Ethical and equitable practice. Ethical care demands equity. Advanced practice nurses must recognize the systemic biases in research and care delivery that impact outcomes for women and LGBTQ+ veterans. The implication: apply the ANA Code of Ethics, especially provisions on dignity, advocacy, and patient self-determination. Quality improvement and data use. Advanced practice nurses play a critical role in using measurement-based care, like PCL5 tracking, to monitor outcomes and improve treatment fidelity. The implication: use outcome data to refine workflows, build local evidence, and sustain trauma-informed care models. So in summary, cognitive processing therapy significantly outperforms SSRIs in reducing PTSD symptoms in veterans. Most studies showed PCL5 score reductions exceeding 30 points with CPT, while SSRIs provide only modest benefit, particularly as monotherapy. Based on these outcomes, multiple clinical guidelines, including the VA, DoD, APA, and NICE, identify CPT as the preferred first-line treatment. SSRIs are still useful, but typically in adjunct roles or when therapy is inaccessible. Finally, veterans respond best to care that is integrated and team-based. Advanced practice nurses should lead interprofessional efforts using measurement tools like the PCL5, coordinating therapy referrals, and supporting holistic, culturally sensitive care delivery that addresses both clinical and functional recovery. Thank you for taking the time to review this presentation. To ensure accuracy, ethical practice, and alignment with current standards, I've included all the sources referenced throughout, ranging from clinical guidelines to nursing ethics and policy frameworks. These sources are not only academically essential, they are also tools we can use in our daily roles as advanced practice nurses to advocate, lead, and deliver trauma-informed, patient-centered care.